Good morning. With the repeated episodes of waves of COVID, we have learned to live with COVID as well as manage patients who have other issues like a stroke along with COVID. Welcome to Stroke Rounds episode 45.
55-year-old female, known case of rheumatic heart disease, severe mitral stenosis, atrial fibrillation on warfarin with INR 1.7, presented with left-sided weakness, so sudden onset from 11 a.m. and she was found to be COVID positive.
So this poses a couple of unique problems. One, the INR is 1.7. So thrombolizing this patient may not be safe. So the option is and patient has got a dense deficit and patient is COVID positive. So routinely we shift the patient to the CT scan room, get a CT angio, then decide on further management like a mechanical thrombectomy. But in this particular situation, we thought it's better to shift the patient directly to the cath lab. Let's see the patient. So this is the patient.
Patient is having a left-sided dense hemiplegia, a left UM facial palsy, and gaze preference is also there, suggesting a large vessel infarct on the right side.
The gaze paresis usually suggests that the patient has got a large vessel occlusion and with a high NIH score. So the patient arrived in the emergency room at around 3 p.m. And so it was decided to shift the patient directly to the cath lab rather than shifting to the CT scan room. Expert CT was done in the cath lab, which is a modified CT scan which can be done in the cath lab itself, and it is enough to rule out a intracranial bleed. Since the patient had a dense deficit and with a gaze paresis suggesting a large vessel occlusion, the patient was taken up for a DSA.
This is a right common carotid artery lateral view showing normal common carotid artery, external carotid artery, and internal carotid artery. It is proximal part is almost normal, and distal part we can see a sudden cutoff with a crescent type of occlusion. In zoomed image, it is evident that shape, crescent shape, is very much evident, and we can see the posterior main branch, that is posterior communicating artery, and above that we can see anterior choroidal artery. In the front we can see ophthalmic artery.
So the occlusion is distal to the anterior choroidal artery. So you can see the posterior communicating anterior choroidal and ophthalmic. So it's beyond that, and there is a typical crescent shape or a meniscal sign suggesting that this is most likely a thrombus. The option is to, and this is another view which showing the posterior communicating, filling the both posterior cerebral arteries, and the lateral view you can see the posterior communicating artery filling the posterior cerebral and the distal basilar and the superior cerebellar also. Here you can see the posterior communicating supplying the anterior circulation when vertebral shoot is done. So the patient was taken up for a mechanical thrombectomy using the Solumbra technique, where an aspiration catheter is guided to the face of the clot and through which the microcatheter is advanced into the middle cerebral artery, and a check shoot is taken to see the patency of the distal vessels. The stent retriever is deployed, and under aspiration the stent retriever is withdrawn along with the aspiration catheter under aspiration. And immediately after that you see that the vessel has, first pass itself, the vessel has opened. But what do you see here?
We can see an early division of MCA into superior inferior division, and in superior division showing proximal narrowing, suggestive of it may be due to a spasm of the vessel, or it may be due to an underlying pre-existing stenosis due to.
So here you see a early division. So this is one of the problem we discussed in the previous sessions also, that when the, if you take the bifurcation of M1, middle cerebral artery, into two branches as the M1, so this is a very short M1. But for doing a mechanical thrombectomy, this lower division which is very large, you can go easily up to this region and do a mechanical thrombectomy without much of problem. So it is the anatomical shape and size of the branch which decides the feasibility of doing a mechanical thrombectomy. So what are the options to do? There is a significant narrowing of the origin. So when the stent retriever is deployed, that can produce some amount of vasospasm. So one option is to give intraarterial nimodipine and see what is the response. After intraarterial nimodipine, there is marginal improvement. You can see the lenticulostriate arising from the superior division. Here also the lenticulostriate is seen well. This is arising as a single branch and giving rise to the branches of the lenticulostriate. There is a minimal improvement in the spasm. So probably it is vasospasm. So what else you can see here?
You can see there is a good cross flow, ipsilateral A1 and ACOM can be seen, and opposite side A1, and both ACA can be seen.
So
And
this is a circle of Willis which is complete. So you see, have the posterior communicating artery which is open. The ACOM is very large. It is cross flow. So it is a good circle of Willis. That is a good situation for the brain, because circle of Willis will support the brain when there is an occlusion of one vessel. This is the clot which was taken. There was a small fragment also, but vast majority of the clot which was in the shape of the vessel came out as a single piece. This is one advantage of doing a Solumbra technique, where most of the time the clot comes out in toto. And this is the patient in the COVID ICU on the day 2. The patient showed improvement. The upper limb power improved to grade 2, and the lower limb power was much better, almost grade 4/5 on the day 2. You can see the improvement in power. Patient was managed in the COVID ICU. She did not have much of complications due to COVID. She was discharged, and 1 month review shows that she's much better. She is ambulant without support. Upper limb power is improved to almost grade 3 plus. Speech is normal. Facial palsy has improved. So COVID taught us so many things. Now, we have to learn to manage patients with large vessel occlusion, even with COVID. So we have to modify the protocol accordingly. When one suspects a large vessel occlusion, it is better to, if feasible, better to shift the patient directly to the cath lab, so that exposure to a large number of people can be avoided. And second is, post procedure, when you do a fumigation, you need to fumigate only the cath lab. Otherwise, you will have to fumigate the CT scan. You will have to fumigate the cath lab. 2 areas needs to be fumigated. And second is that it will disrupt the functioning of the CT scan, because at least for 1.5 hours, the CT scan should be closed down. So this is one modification, a direct shift to cath lab. This is also called a one-stop stroke solution, where the cath lab becomes the area where the patient is directly shifted from the ER, where a CT scan can be done immediately and decide whether the patient needs IV thrombolysis, which can be done on the cath lab table itself, and proceed immediately with mechanical thrombectomy if it is indicated. This saves significant amount of time as far as the recanalization is concerned. Thank you. Please do share your comments, thoughts, opinions, suggestions if you have. See you next time with another episode of Stroke Rounds. Thank you.